right anterior oblique caudal view, and for the LAD, we use the AP cranial view. Now, our arteries were recorded at 15 frames per second, so that's about 0.006 seconds for one frame. They were stored in the EPIC system, where the reviewers could access them and examine them, and using the key system on the computer, you could select key image and use the up-down arrows and review each frame of the angiogram separately to observe the flow dynamics. So for our results, I just choose one patient's case here to look at, where we have a 68-year-old female. She is 136 pounds, about 5'1". She is a non-smoker and she does not have diabetes. But she does present with tachycardia and chest pain with a complaint of about 4 out of 10. Her labs are for the most part normal, except for an elevated troponin T of 99. In these images, these are sequential images or frames of her angiogram during systole. The right curve or line indicates the margin of the heart, and of course the arrow is trying to indicate to you, or I'm trying to indicate to you with the large red arrow, where the heart is as it's moving and contracting. And of course the vessels are labeled. So when contraction first begins, and we go through these frames, we can see that very little blood in white displaces the contrast in black. So there's minimal entry through the 4 phases or 4 time points of contraction of blood into the left vein. If we look at distally, that situation changes. So if we look at the same time frame, 4 frames of the angiogram, and as the heart muscle relaxes, you can see the big red arrow coming back out to the border. Okay. Suddenly, there's a big rush of white or blood replacing contrast and black through the left main and even in the proximal LAD. And this continues even further over a greater distance into the LAD and then into the left circumflex. And that's evident by the mixing of contrast and blood in white, so we kind of get this grayish appearance. In the next phase of distally, or relaxation, this continues further, and there's even more of a distance that's covered very rapidly in both arteries. And in the final phase, the blood has actually gone past the branching point in the LAD. So this is the angiogram without any slow motion effect in this patient. And then these are all the frames pieced together using the slow motion effect. I kind of like that one better in the slow motion video because it's easier to visualize what's happening. I'm going to let this restart here. So now the index artery is full. There's not much blood going through the left vein, but as the heart relaxes, you see the rush of white blood replacing the contrast in black over a great distance. And this continues, of course, until the contrast is completely wiped out of the myocardium. These are just freeze frames during the angiogram of the point between the end of systole and the beginning of distally. And the red arrows indicate here a point where there's a more sharp division between the contrast in black and the white blood, the blood in white that's coming through the artery. We call this a collision line or a line of separation. And then what happens at the beginning of relaxation, more blood rushes in, and we get this more grayish appearance because we think that that indicates the initial turbulence of the blood rushing in, mixing with the remaining contrast. Turbulence inside the arterial lumen can cause damage to the intima, just like what we see in industrial piping. When there's turbulence of water and air bubbles in the pipe, the inner coating of the pipe becomes pitted and damaged. In the case of coronary arteries, we call this type of injury, in this instance, reperfusion injury. So, as far as the physiological anatomy is concerned, in systole the ventricles contract, and distally the ventricles relax. In systole, there's antegrade flow. Initially, we observe that the left main is completely filled with contrast, and blood slowly moves in. So antegrade systole flow is what we see in the heart. Why? Because the pressure is higher in the aortic root and the left main, but the flow is slow, secondary to the resistance created by myocardial compression. Then when the heart relaxes, when the myocardial relaxes, blood in white was observed to move quickly, displacing the contrast in black. And the reason there, or the rationale is that the pressure in the left main remains high and higher than in its branches. And there's less resistance now to flow due to the relaxation of the cardiac muscle. And then we look at flow and collision during the transition from systole to distole. Okay? And we have a line that we call the collision line. And this is where we think turbulence occurs and then reperfusion injury. But I left a loose end, and I try not to leave loose ends. Okay? And the loose end here is that there was no abnormality seen in the left coronary arterial network. So how do we explain the tachycardia, the chest pain, and the troponin level in this patient? And for that, we looked at the nuclear perfusion scan of the patient. And if you look at this area here and here, there's no intense or bright color. And if you look at what those regions represent, that means that there's less blood flow in the inferior and apical wall. The coronary angiogram of the right coronary area was subsequently done, and that did show a mild lesion. And putting that together with the troponin level and the signs and symptoms that the patient presents with, we diagnosed right ventricular infarct. And the treatment in this patient was a balloon angioplasty of the right coronary artery to relieve her symptoms. What do we conclude? Well, what this research presentation suggests is that we can use principles from fluid dynamics in the HVAC industry and apply them to the coronary arterial network to observe the flows using a new technique called dynamic coronary angiography. The results of this study suggest that during distole, antegrade flow is fast, it's rapid, in contrast to slow antegrade flow during systole. Perfusion of the myocardium occurs during both myocardium contraction and relaxation, and that collision between flows can lead to turbulent flow that may lead to injury of the intima and begin the development of this atherosclerotic process. Why is this important? Because faculty and students of medicine need to be aware of new knowledge like this, because it gives us a better idea of how the coronary arterial network works and how we can predict problems in the coronary arteries and work toward favorable outcomes for patients. I'd like to acknowledge my team members, especially Dr. Thach and Nguyen, who's sitting here in the center at the front. He's really the innovator of this and our team leader and our mentor. The funding was all internal, and I hope I've done a good job in explaining antegrade systolic flow and diastolic flow to you. I'd be happy to answer any questions that you might have.
So, someone close to me years ago at a young age died of a heart attack. And, they had put a stent in earlier in the day. He was actually an ER doc that died into his ER. So I'm thinking about this, when you put a stent, and I don't know the anatomy that well, but when you put a stent in, you're now
stent, you're using mechanics, some kind of mechanical structure to restore the original anatomy, to restore the lumen. And if you restore the lumen and the shape of the vessel, with the principles of fluid hydraulics, fluid mechanics, the blood flows through in a more laminar fashion rather than a turbulent fashion.
But I'm talking about more at the borders of the stent, right? Because they're going to be going more like this, where the stent seems like it will be maintain a solid volume throughout.
Save me.
Dr. Nguyen, I would say it opens for flow. So the more flow there is, the more the diameter is open, more blood flow, less turbulence. The narrower the lumen, because of a plaque or per se blood flow is slowed down, the more turbulence. So actually this is why we restore, like you said, we restore the anatomy by opening patent flow. It's kind of like a hose. This is how I tell my students. You turn on the water, there's no kink in the hose, water flows with ease, there's no turbulence. But if it's bent and kinked somewhere, it's the same idea. If you have plaque formation somewhere, then the blood flow doesn't move as fast. And that's where you can cause other clots. So, segue to my question was, can someone get, and I've seen it, a myocardial infarction with completely patent open vessels? And what would your answer be? Yes. Why? It has to do with the dynamics and velocity of the blood flow. If the blood flows slow, we don't go. Blood gets stuck and it forms clots, right? So hypotension or hypovolemic shock, or someone who has low blood pressure to begin with, even if they have beautiful open, they do an arteriogram, everything's open, and lo and behold, the little old lady dies. That's happened, I've seen that. It's because of the low blood pressure, which can be caused by a primary heart block, where you can see a delay from the SA node to the AV node. So then the AV node takes over, so the cardiac impulse is slowed. So instead of a normal 60 beats a minute, you're at 40 beats a minute. Now, someone who's at 40 or 50 and athletic, that's great. But a little old lady who's at 40 or 50, the blood flow is slow, and that's going to cause probably a clot either at the right coronary, the left coronary, the anterior interventricular artery, things like that.
I think Dr. Nguyen is probably best.
Thank you.
You go first, because you're probably,
You should come to give lecture to the cardiologist.
Yes.
Beautiful, and you say very nice, beautiful. Just one thing very clear. When we put a stent in, we have to expand the stent and touch the wall very well. We expand it. We almost stop all the movement of the wall. Because if we don't do that, like you mentioned, the artery is still contracting and constrict and then relax, because the artery still contracts and relaxes. It will cause blood clot, thrombosis, thrombus, and cause the occlusion of the stent. So when we expand the stent, we expand more than usual to be sure the strut of the stent touch clearly and at the wall. So number one. Number two, I agree with you that you said everything very good, very good. The flow, we will show the next slide. At first we have reverse flow. We have antegrade and retrograde, and then we have collision, and this is the area of the disease. Now we put a stent. When we put a stent, we make the artery, the wall straight, and so the flow is much better, and it becomes laminar, and we don't have collision. This is the beneficial mechanism of stenting. We change from turbulent to laminar.
But wouldn't the stent, by opening up one area, create a collision in some other place in turbulence?
Usually, we have very clear. I have picture of before stenting, baseline, and after stenting. If we have a long stent, you can cause it, no question. But if we have a short stent, the flow is very good, And
It just
so,
protects that
and we
area.
don't have trauma. And the beneficial effect was proved by evidence, clinical evidence for the last 20 years when we begin to have stent. And so, with the result, we change clearly, the stent does not cause more damage unless, like she said, unless we did not expand the stent enough, and when we have curved artery, we cause angle, then we cause turbulence inside the stent. Thank you very much.
I have a question, sort of, I guess everybody, but, so I'm just thinking through things. My father's got a really strange cardiac stuff that's been going on for like his whole life, and he has Talarico syndrome, and so his heart will go from like really high rates and then really low rates, and then he's got an ascending aortic aneurysm, so then they're putting him on all kinds of medications. And he keeps going into the hospital and saying, I have chest pain, but every test comes back negative. And so, so you were talking about, right, that they keep going in looking to see if they need to put a stent in, does he have a blockage? Every time, no blockage. And so they're like, I don't know, and then they're like, I think it might be GI, you may go see a GI doctor, but he's had chest pain for like 20 years, so he's pretty good
How
at
big is the
identifying.
aneurysm? Size of the aneurysm. What is the size of the aneurysm?
Oh, right now he's at 4.9, so they said, I think it's 5.5 that it becomes like an emergency, and I think 5.2. If, one doctor said that if he wanted to do like preliminary surgery to, but I guess there's one doctor in Texas says that he will do, there's a new procedure where you can, that doesn't require to do open heart surgery, but he said he won't do it at 5.5, and he went from 4.7 to 4.9 within the span of 2 months, so he is kind of like, I don't know, I really don't want to just, because they were only monitoring him every 6 months, so he's just worried that he's going to go from 4.9 to 5.5 and not know it, and then end up having a rupture and dying. So he's, the person that's in St. Louis will do it at open heart, so pretty invasive, at 5.2, so, but I was just thinking, with your statement that maybe it has to do with today's lecture, right? The flow changes, especially if his heart is going in between, and then medications that they're using to try to make sure that the aneurysm doesn't get bigger, possibly being the reason why tests aren't showing anything, but there really is an underlying issue. But I don't know, I just was thinking that maybe it might be relevant to the flow changes, and when we're talking about, how
So in this patient, we have to say, does the patient have chest pain because of the aortic aneurysm, or does the patient have chest pain because of coronary artery disease? If the patient has chest pain from aortic aneurysm, then we say, is it because the expansion of the aortic groove causing the chest pain? That first. So if it is, then we have to change the aortic groove. This is a big surgery because we have to take off the whole aortic groove, put a new prosthesis in, and replace and re-implant the coronary arteries. This is one. Now, if it is because of we do the angiogram and everything look clean, then we have a second part of my research. The arterial phase of the flow is wide open. We see in many women, we talk about symptomatic women, they have patent coronary arteries, they have chest pain because the flow is so slow. The arterial phase, you see? So we have to see, is it because the arterial phase of your dad is down? So this is why we don't do the surgery why we're putting the 5 centimeter in the aortic groove, because we don't want to, because above 5 centimeters, then the chance of rupture is higher. That's all. So this is why.
Okay,
Yeah,
thank
very
you
much.
so much.
Can we go to the next one, please?
Yes, sir.
And for my part, can everyone hear me clearly?
Yes.
Okay, yeah, thank you. Okay, I will introduce about the chain from laminar flow to turbulent due to collision between the arteries against the retrograde flow. And this research has been also performed by Dr. Nguyen here. So for the outline, I have 5 important parts I would like to introduce. The first one is normal flow, is laminar flow. And the second one is very interesting here. I will show you in the turbulent flow happens based on the physics phenomenon like Bernoulli equation. And the third one is the images of the collision. And the fourth one is the collision line. And the fifth one, I will present a simple clinical case to illustrate. So, for the definition of the laminar flow and the turbulent flow, the laminar flow we can see here in the first one, the first images here, we have the artery and the diameter of the artery D right here. The laminar flow is very well organized, and this one is the turbulent flow. The turbulent flow is very disorganized in the arteries. For the laminar flow, this one is the angiogram of the right coronary artery. And we can see here the black color is the contrast and the white color is the blood flow. In the laminar flow, it's very organized, so the blood flow in the white color, so we can see here very organized, and it has the point tip right here. So for the next one, the turbulent flow. For the turbulent flow, the definition is very disorganized flow, and we can apply the physics equation here, and we call that this is the Reynolds number that represent for the turbulence, and the Reynolds numbers equal V times D times P and divided by Iliac. So the V is mean velocity, and the D is vessel diameter, and the B is blood density, and the Iliac is the blood viscosity. And based on this equation, we can predict and to calculate the characteristic of the turbulent flow. And we can see the conclusion here. Turbulence, the Reynolds number will increase when the velocity and the diameter of the artery increase, and will decrease and the denominator increase. That means the blood viscosity increase. For the figure 4 here, I have an example. This one in the aortic, the angiogram of the aorta, and this one is aortic root, and this one is aortic arch. So the contrast is still in the black color, and the blood in the white color, and we have the turbulent flow right here, very clear, the mixture between the black color and the white color. And for example, the figure 4D, the blood from the aortic root passes into the aortic arch, and the blood in aortic root is quite disorganized, the mixture between the black color and the white color here, for example. So, and the next part will be the images of the iliac artery. So for the figure 5A and 5C, here is the beginning of the turbulent flow in the iliac artery. At the beginning, we injected the black contrast into the iliac artery. For the figure B, the blood in white color, I just introduced it. This one is laminar flow, very organized, and the point is very clear here. And for figure C, the laminar flow stop abruptly at this position with all the layers recoiling each other. So we can see a little turbulent flow here, not very clear, but I will show you in the next slide. For the figure 5D and 5F is the turbulence at the heart of systolic flow in the iliac artery. So for the D, for this position, is very look like the cigarette. Yeah, very white color. For figure E and F, the blood in white color is still disorganizes. And from the curve right here, the blood will start mixing together with the contrast. And the blood with the less viscous occupies the apex of the curve, and the contrast in the black color here occupies the larger part in the inner curve. So for this case, the distal flow is pushing back on the retrograde direction from the distal segment to the proximal segment of the iliac artery. For figure 5G and I, the turbulent flow in the iliac artery, the contrast is still in the black color. In pushing up, we can compare the three figures here. You see, so at the beginning here, the contrast in this position and still moving up here and moving up here. So this is the evidence of the slow retrograde flow during systole. For figure 5J and 5M will be about the strong retrograde flow in diastole. The blood in white color in turbulence here is still very disorganized, and the contrast is bursting up further. See here, clear. So the dark color stay at this position, moving up here and moving up here. So this is the strong evidence of retrograde flow during diastole, because this is the iliac artery, and iliac artery is the peripheral artery, and why the retrograde flow happens in systole in coronary artery. So for figures 5N and B, is the interchange from retrograde to antegrade laminar flow. So for 5N here, the contrast is moving to the highest point here in the proximal segment of the iliac artery. This is the highest point. It can move up anymore. So just stay here, the highest point. And for the figure O, the blood, Y begin moving forward. Here the blood in the white color moving forward to the distal segment. And for figure B, very interesting here, the blood is forming again in laminar pattern. Why we know that this is laminar flow? Because this is very organized flow, and it's at the point tip here, and it represents for the closing of full cycle of systole and diastole. So for figure 5C and 5Q here, this is the two examples of the complete cardiac cycle of the laminar flow. So the location of the collision of the antegrade flow and the retrograde flow stay at the same place, and we usually see on the patient has the lesion at the middle of the iliac artery, as well as the coronary arteries usually happen in the middle segment of the artery. So I can wrap up with the clinical case here. So this is the angiogram of the left coronary artery, and the concept is still the same as in the artery. The black color is the contrast, and the white color is the blood flow. And the case here is a patient came to the emergency room with chest pain and the angiogram. So the most of the lesion at the mid LAD, and the collision line here, the white arrowhead here is the collision line, and the turbulent blood flows have been clearly observed. So why we know this one is collision line? And because the blood flow will start from the left man and to the proximal segment of the LAD. So the blood losing the point tip here, and the mixture between the black and the white color, for example here, this is we call the collision line between the retrograde flow and the antegrade flow. So for in the patient with severe hypertension condition or uncontrolled hypertension, the left ventricle will react more pressure, very strong pressure, and push the blood flow back to the proximal segment of the coronary artery. So, and this reverse blood flow will collide with the incoming blood flow here at the middle segment and will create the collision line and will trigger the arteriosclerotic process. And we observe so many patients and see that the collision line usually happens at the middle segment of the coronary artery as well as the right coronary artery. So, and the anatomical perspective indicated that collision line developed in LAD during the change from diastole to systole, and the fluid mechanics perspective expressed that the turbulent flow being defined as irregular. So that makes sense because the definition of the turbulent flow is very disorganized. The black and the white color, the collision of incoming flow, and the antegrade-retrograde flow, this is very irregular. And the coronary anatomy perspective confirmed that turbulent flow could be seen at the entry of the left main region and the mid segment of the LAD or the RCA, the right coronary arteries. And for my summary, there are two important things I would like to introduce here. Is in the coronary arteries, turbulent flow occurs at the site of collision between the antegrade with the retrograde flow. And the second important discovery was the identification of the location of collision line, where the antegrade flow collides with the retrograde flow and where the lesion develops in coronary arteries. And so I finished my presentation part. So do you have, thank you for listening. Do you have any question for me?
No question. So
Oh, you go ahead.
when you have the plaque and you identify it, is that when you find the collision line, or do you find the collision line then you find the plaque?
Okay, so
The lesion, is it identifiable first, or do you just immediately look for the flow and find the collision line when diagnosing?
okay, because the patient came to the emergency room with chest pain and with the high blood pressure or hypertension. So we took the CAG and showed in the lesion here because we know that the definition of the laminar blood flow very organized in the white color. But in here, the reason here is the black color and the white color mixed together, and we can define that based on the observation. We define that this location is collision line.
Yeah.
She asked about the pathophysiology of the lesion. So at a young age, if the patient had uncontrolled high blood pressure, the patient would have the collision line with no lesion yet.
That's what I was asking.
But slowly, with uncontrolled hypertension, high cholesterol level,
You
then the
build,
patient will develop.
yes.
And
you
then
build.
develop the lesion. And then at the middle age, at that time, they develop unspun angina or acute MI.
Got it.
She asked about pathophysiology.
Yeah. Thank you for clarification.
Any questions? Yeah, go ahead.
What's the reason for retrograde flow?
Sorry.
What's the reason for the retrograde flow?
Retrograde flow. The reason.
No, very important. Uncontrolled high blood pressure. So let's say how we know that. So I have a patient who had acute MI. So the first one, I fix the right coronary artery, and we look at the iliac artery. We have a retrograde flow. It's due to severe distal vascular resistance, heightened vascular resistance. So then we give the medication to control the blood pressure. 3 days later, I did an angiogram, angioplasty for another artery, not causing the acute MI. We could stage acute angioplasty like that. And at that time, we check again the the collision. Then we have it less collision. But then a month later, she came back and complained of chest pain. Usually we don't do the angiogram, but this case I did because I want to see how's the pressure in the leg. Clearly, with good control of high blood pressure, good control of with medication, clearly the collision in the iliac artery disappeared. This is the first time we prove that if we control the good blood pressure, then we could reverse the mechanism of disease in this patient. So this is, thank you.
That's cute.
Yeah, thank you so much for listening.
So continue with the very new techniques what we use for the angiogram. I have two very interesting images that we record when we do that with new technique. The first is the ballistic trajectory of the coronary artery flow in correlations with the length selection and the curving during car racing at Daytona Beach. And at Daytona Beach, for experienced drivers, when should the driver use the corner at the turning point and where the cars should hit the apex, and after that, you have the subsequent extreme high speed run at the next corner is our idea of what we observe during this angiogram, and there's similarity of these images. And these are the schematic of the car racing with the figure 8 is the when the drivers need to select the bat 1 and bat 2 when the peak or the when he should choose the peak of the curve or the curve, and figure B, he can choose between bat 1 and bat 8, bat 1 and bat 2. If he chooses the bat 1, then he must decrease the speed, or if the car do not decrease the speed, he can jump out of the car racing. And if the driver chooses the bat 1, the velocity must be changed. He decrease the speed, however, it's not very excessive because it could make a spin. And this is the schematic of where should the car drivers use the apex. There's the apex we call at the figure B is the early apex, or figure C is the late apex. And usually the car racers use the late apex as the best strategy for the slightly low, the best strategy with a slightly lower entrance speed, but faster exit speed. And when we arriving at this exit, the car will begin with the straight lines and maintaining the highest speed until the next corner at the figure D. And this is the schematic of the layers of the blood flow over the chaining over the curve. And we can see the faster moving element is in the centers of the pipe or the artery. Will swept away to the outer side of the band at T1, and after that at T2 they change from the center they change swept away and to the outside of the band, and replaced by the slower moving fluid from the inner wall from T1, from T2 to T1 and to T3, to T2. And it's the new technique of the angiogram when we record moving from the axis of the blood. And similarity, there's a contrast in the black color with high viscosity, and that occurs in the inner curve. And the blood is in black arrows is moving around the inner curve. There's similarity of the images from figure A to figure C. The flow from the ostium to the end of proximal segment. The blood go around the corner and reach the right side of the tract. And figure D to figure F as the next band of the left header. Continue using the early apex, very similarity to the apex in the cat racing, crossing the midline to position. And another similarities of the images between the recirculating blood flow above the flow above the wings of the airplane during takeoff and the access shoulder of a coronary bifurcation. So this is the schematic of the turbulent flow at the wing of the airplane. In order of the airplane to rise into the air, a force must be created to exert the force of gravity. We call this this force in the lift, and it's created by the flow of the air over an airfoil. At the shape of the airfoil, we cause the air to flow faster on the top than the bottom, and the differences of the pressures over the roll up of the airfoil or of the airflow. At the rear of the wind, we will also creating a turbulent flow, which traveling the downstream of the wind tips. This schematic is a clear of the where the pressure differences and where the recirculating or turbulent flow should be formed. The velocity map of the fluid during the course is observed at the point P, at the point P as the middle of the opposite side of the airfoil, and at the velocity at knees of the wall is reduced by the friction strap. The wall strap will strap at point S is reduced to 0, and from this point the flow, reverse and recirculating will develop, and at point S, we call the point of separation. The turbulent flow should be occur at that side. And it's the side where the turbulent blood flow will be formed. At the start of the upstream, the resulting turbulent flow happen downstream. Can also occur in many cases of coronary bifurcation. The situation is more complex because the lesions can occur at many branches. At the proximal of the point of bifurcations, at the bifurcations angle and distal to the bifurcation. And this is schematic of the bifurcations. Bifurcation lesions. The distal of the lesions could develop in the internals or lateral side of the side branch or the main branch. However, the source of the flow disturbances can be located at the upstream of the lesions or the proximal of the bifurcation angle. And at this schematic, we see as figure 8, at the proximal collisions, the flows in antegrade and the turbulence is at the outer curves of the small side grains. And at figure B, in the distal collisions, the flows is retrograde and the turbulence is at the confluent areas at the side of the small coronary artery at a small side range. And these are images of where the turbulent we observe at the axis at the left circumflex artery. As image A, the axis is completely filled with contrast, and then blood flow in this image. From image B and C, the flood in white color enter the axis by the inner curve along the carina. The carina is the divisions of the left main and axis, and image D and E is the we call we see very clearly the recirculating flow is formed at the axis. It is a very clear turbulent flow become prominent seen in unorganized mixtures of black colors in contrast and white colors of blood. The turbulent flow is as the axis struggle of the axis. Injury can the injuries in edema and the start of atherosclerosis process. And we come to some conclusion. The new technique of coronary angiogram is provocative and useful to explain fluid dynamic activities. And there are similarities of raising F1 with lens selection and coronary artery blood flow. There are similarities between recirculating flow above the wings of the airplane during takeoff and at the axis shoulder of the coronary bifurcations. Thank you. And come to conclusion, and if there are any questions, please go ahead.
We have 5 minutes left. First, I would like to thank all the faculty who came here on this Sunday morning for this meeting. The reason why we presented, because like the first message is, now we have very clear the coronary flow in systole and diastole. In systole, it's fast flow, in diastole, it's fast flow, and systole is slow flow. You can read another book of physiology and they can say differently, no problem. Then we have to say, where are the references? You have the email that Talarico, he can send you the picture. And this is the most important one. So right now we have very clear, we don't have any doubt about it. Number two, the second presentation, the main message is the lesions happens due to first injury in the intima by the collision. If the patient develops uncontrolled hypertension and has high lipid, hyperlipid, high cholesterol level. So let's say, for example, now, if so, can a child have heart disease? Well, at that time, the artery is small. So there's a Bernoulli equation, the V and D. D is small, no turbulence, you see? So it takes time for the person to grow and then the artery become bigger, then we can have the D to begin to have turbulence. So the child doesn't happen. But can a 10-year-old child have heart disease? Yes, if the cholesterol level is 600, LDL 600, instead of 100 like you have here, you see? So this is very important. The second message is we know that the first injury is from the mechanical injury. And the last one, the presentation, I know that You are faculty teaching anatomy and physiology. It is a knowledge, but it's also an inspiration for the student and have to make fun. This is a lesson. That's what we talk about Daytona Beach car racing, or I'm from Indiana, we talk about Indy 500. We are excited about that. And also about the airplane. Here in Florida, a lot of people fly an airplane, you see? So this is why we show that, and we show the similarity, and it's real. I use hydraulic principle to explain everything for coronary arteries and arterial flow, and it could come out so beautiful result. That's all, and thank you very much.
You have a question?
Yes.
I'm sorry, so thank you very much for a wonderful presentation. I just want to make sure that I understand. So my understanding is that your conclusion is that during systole, the coronary flow is the lowest.
Yes.
And can we generalize it for all arteries, or it's pertinent to a specific artery?
So very interesting. The blood flow, the blood came in coronary artery is in diastole. But in the artery, the heart, the hand and the leg, it's in systole.
Right.
It's the reverse. You see? So this is why you see that Dr. Talarico, he shows the systole and diastole only 4 pictures. Why? Because the heart rate is 110 and 103. In the normal person sitting here, we have the heart rate of 60, then the diastole should be 4 frame, and the systole should be 7 frame. But in a fast heart rate, then the fast heart rate, that the systole has only 4 pictures, and the diastole have 4 pictures. You see, so in the arteries, clearly different, because in the coronary artery, the flow mainly in diastole, but in the leg, the iliac artery, it is in systole.
I mean, this conclusion is pertinent to all coronary arteries.
Yes.
All coronary arteries.
Both sides.
Yeah,
Arterial.
that's what I meant.
Yeah. Thank
And
you.
the other question I had is about, my understanding was that there was a phrase, something that contrast is high viscosity. Now, and well, the area with the contrast has high viscosity. Is it interaction of the contrast with the blood, or what would
Compared with the blood.
compare with the blood?
Yeah.
I see.
So this is why you see that in the iliac, the contrast stay in the inner curve.
Right, we saw
See?
that.
But the blood is at the apex of the curve.
Right.
This flow. So this
So what underlies this difference? So you're saying that the contrast has higher viscosity. Now the contrast is made of particles which have high viscosity compared to blood. What is contrast made of? I'm not a clinician, and I just want to make sure that I understand. The contrast is
the material.
a suspension still in the blood.
To tell the truth, I don't know.
I see.
I know that it's more viscous. That's all.
Okay.
Thank
I
you.
yeah. My next question is, in your experience, is there a higher incidence of plaque formation along these curved arteries systemically? I know you mentioned, we focus only on coronary, but I'm talking, you mentioned iliac. Areas where there's more curvature, is that a higher risk, anatomically speaking?
It should, because the right cornea is a C, and the lesion is in inner curve. Why we have to know about that? Because when we do the angioplasty, we put a wire, and we go to the apex, we curve the apex. Say in a patient with acute MI, the artery is closed because of thrombus, so we don't know where it is. Then we have to put the wire, we follow the apex to go to the lumen, it's a true lumen. If we go to the inner curve, we can go under the plaque, and we can dissect the artery.
Right,
So it's very important.
yes.
Thank you. We finished because we have the next session. See? Thank you.
Good questions. Yeah, that's what good question.
I know